I take this opportunity to welcome you to this CUAMM function, and I'm here to try to tell you what we are doing for the last mile in health. Is it this? Yeah. So I give you very quickly a general overview of what CUAMM is doing in Uganda, but more specifically on what CUAMM is doing in one of the regions of Uganda that is extremely difficult to deliver results. But nonetheless, we are trying to make headway in trying to achieve something for the poor women and children in that area. In this year, 2013, CUAMM in Uganda ran projects that covered 11 districts with a population of about 2.5 million people. But the area of Karamoja, which is in the, oh, how do I? Oh, this is not working. Go back a bit. Yes.
You must say next.
Okay. So can you go back a little bit? Just go back a little bit. Yes. So that area in the northeast is where we have the highest concentration of effort right now in Uganda. Next slide. We are having a basic health system framework in trying to address the health system problems in Uganda, and especially in that northeastern region, that is looking at all the aspects that start with governance, leadership, management, supplies, finance, human resource, and so on. So this is the framework in which we are working and try to achieve results and impact through it. Next slide. So the main areas of our project in health management capacity building, because we realize that even with the little resources that are there, we can achieve a lot if they are managed very well. So we are working very hard with the district local governments to improve the management capacity of the local district health systems. And this year we are having a very intense activity in trying to improve maternal and child health. And we are in the area of HIV/AIDS, particularly the prevention of mother-to-child transmission of HIV. And the CUAMM right now is the lead implementing partner in the whole of northeastern region in Uganda, in a partnership that is contributed by UN agencies and also the US government PEPFAR funds providing support. We are also strongly supporting health training, both through scholarships and supporting training schools directly. CUAMM and UNICEF in Karamoja initially started work together because of the support from the Italian Ministry of Foreign Affairs, or MAE, but since then we have established an independent partnership with UNICEF and are trying to do a lot and reaching people in many ways in 7 districts in northeastern region with a population of 1.4 million people, and we are working with 112 health facilities, 5 of them are hospitals, and 1,434 villages. Next slide. Karamoja and CUAMM are buddies for a long time. It has been since the early 1970s when especially Dr. and Mrs. Rowe, who is here, started work in Matanya Hospital. CUAMM has continuously been in Karamoja since then, and Matanya has been the main base. But it has really grown, and CUAMM has grown with the hospital. CUAMM and the support to Matanya has been seen as a symbol of Italian interest in Karamoja, and sometimes in Uganda there is loose talk that Karamoja is Italian territory because of a lot of interest and visibility of Italian organizations working in Karamoja. Recently, the First Lady in her visit to Matanya Hospital said that Matanyi is a symbol of hope for Karamoja because everything else seemed to have been failing when she visited many hospitals, institutions, and so on. They were in a very serious state, having so many problems. But at least when she came to Matanyi, she had a sign of hope. Next slide. Yes, Karamoja, compared to the rest of the country, is a very difficult region, very bad indicators, and there are just a few of them there that you can see. The life expectancy is almost 4 years less than the national one. The population living below the poverty line is almost 76%. That is living on $1 a day. $1 here might probably buy you only a cup of cappuccino or even less, I don't know. Then maternal mortality is too high, 750 per 100,000 compared to 438 for the rest of the country. Infant mortality, 87 versus 54. Under 5 mortality, 153 versus 90. Malnourished children, almost 37% compared to 28%, and so on. These are very, very bad indicators, and so it is really showing you how badly off the region, that is the concentration of CUAMM work, is compared to the rest of the country. Next slide. Yes, in Karamoja, there are all too often these common health problems, and we are trying to systematically address them, all of them. So from the problem of lack of good governance, supervision, and management, we are working by providing technical assistance to the district health offices and teams to make sure that that problem is solved. We are trying to work in collaboration with other partners to advocate for increased financing of health in the region. We are working to improve the management of medicines and supplies. We are working to improve the poor staffing. Almost half of the staff positions are empty, not filled in Karamoja. We've been working to improve staff housing, improving professional development for staff, and very strongly trying to improve access. At the moment, almost 59, or precisely 49% of the people in Karamoja live more than 5 kilometers to a nearby health unit, and that's the definition of access in Uganda. And we are trying to bridge this gap by creating outreaches and a number of transport options to make women and children come and access the service. Then we recently did in 2010 a study on factors affecting maternal and neonatal child health that brought strongly the cultural beliefs and practices, for some of which we are trying to address in the current initiative. The status of the roads is beyond the work of CUAMM, but we try to tell the politicians that they need to play their role. And finally, security is much better now, but it's still insecure to move at night from the village to the health center. Next slide. Yes, the problems of accessing healthcare in Uganda and Karamoja are many. This is a result from the Uganda Demographic Health Survey of 2011, and I want just to tell you that there are 3 big things: getting money for treatment, the distance to the health facility, and having no transport are the major things. And this is the focus of our current project. Next slide. Yes, we are trying to really emphasize on population-based results, and for this we have tried to integrate so much our work with the districts. And since 2006, we have been working with the district local governments trying to contribute to solutions addressing these problems. Next slide. This is what, in some fair detail, we are trying to do in Karamoja. We are providing technical assistance to improve governance, supervision, planning, information management, monitoring and evaluation, logistics, supplies. We are giving scholarships to young boys and girls to become nurses, midwives. We are having a very strong maternal child health component where we are building the capacity of staff, giving equipment, lighting maternities, labor wards, mentoring staff, providing tools and guidelines, and working with community health workers called the Village Health Team. And there are new innovations. We are trying to introduce transport vouchers so that mothers can freely travel to deliver in a health unit. We are trying to give an incentive, a gift to the mother so that she can be attracted to come and deliver. And we are using a new birth cushion where mothers can deliver while squatting, and a number of cultural adaptation practices. Then we are trying to eliminate the transmission of HIV to neonates. And finally, we are giving nutrition technical assistance. Next slide. Next slide. So this is part of our work in pictures, mothers happily delivering babies. Next slide. This is the first cesarean section in a health center that had not been operational since it was built. But in 2008, this was the first cesarean section in that health center that is now having almost 20 deliveries, rather 20 cesarean sections every 3 months. Next slide. Yes, CUAMM is strongly trying to have outreach services for people who are very far, as you can see. Next slide. Next slide. Yes, we are training staff. This was a training in the health management information system for the district. Next slide. And we, at one point, tried to say we have been intensively working for the last 6-7 years in all these districts. So what has happened? And these are some of the observed changes, comparing the 2006 and 2011 demographic health surveys in Uganda and in Karamoja. And even if we worked as well as the whole of Uganda, that would be good enough. But you can see here, in many of the indicators, actually Karamoja performed much better than the rest of the country. The change was much greater. As you can see, in skilled birth, antenatal, diarrheal disease treatment, the purple and green are the graphs of Karamoja. So the changes in those 2 years, in those 2 periods, are very, very significant. And for most of those indicators, Karamoja has gone beyond the national average. Next slide. Looking at deliveries alone, this is the trend that has happened since we started in 2006 December until last year, 2012-2013. We have pulled the deliveries in health units from 8.3% to 19%. Because the population is rising, in actual number of deliveries, they have jumped from 3,500 to 12,673 in the last financial year. And I think this is something commendable. Next slide. And as I told you, in this year, this is the first year of a much more intense activity of maternal and child support. So looking at just the 3 quarters, January, March, April, June, and July, September, this is what is happening. And we are really happy that even in the first year, we are seeing such a tremendous change, and we are definitely going to achieve our project target. Some districts actually doubled their deliveries in just a period of 1 quarter. And we really believe that we shall achieve what we want to achieve. Next slide. I think that is the end. So thank you very much for listening to me. I hope...
Grazie.
Okay.
Grazie.